Today I shall be talking about dislocation of shoulder joint. For that we have to study shoulder stabilizers, static stabilizers and the dynamic stabilizers, glenohumeral bone articulation, glenoid labrum. This is the glenoid, this is the labrum. This is the fibrocartilaginous structure which increase concavity and increase articular contact surface area. Ligament, glenohumeral and coracoacromial ligament. And in dynamic there is deltoid muscles. When the deltoid muscles perform abduction, it pushes the humeral head into the glenoid. Rotator cuff muscles. At the red seats, this is the mnemonic, supraspinatus, infraspinatus, teres minor and subscapularis. Talking about shoulder dislocation, the shoulder can be dislocated anteriorly, posteriorly or inferiorly. Anterior dislocation is the most common and inferior dislocation is the least common. Anterior dislocation of the shoulder is of three types: pre-glenoid, glenoid, pre-glenoid, subcoracoid, subclavicular. In this, most common is subcoracoid. Mechanism of injury is fall on outstretched hand with shoulder abduction and external rotation, blow on proximal humerus. Most common nerve injury is axillary nerve, and when the patient presents to emergency, then the attitude of the arm is abduction and external rotation. Now, pathological changes in recurrent dislocation of the shoulder. Bankard's lesion. Lesion of anterior rim of glenoid labrum. This is the glenoid labrum, and the humerus get dislocated, and due to recurrent dislocation there will be lesion on the glenoid labrum. And Hill-Sachs lesion. There will be depression on posterolateral surface area of the humerus. Suppose this is humerus and this is the glenoid labrum, and the humerus is dislocated, and due to recurrent dislocation, the posterior surface of the humerus get depressed. Now talking about diagnosis, presenting complaints. There will be history of fall on outstretched hand and severe pain and even inability to move shoulder. On emergency, the patient will have abducted arm, elbow supported with opposite hand, flattened of lateral outline of shoulder, acromial process, and the lateral epicondyle of the humerus will be flattened. On examination, arm kept abducted, normal round contour of shoulder joint is lost, becomes flattened, and fullness below clavicle due to displaced head. Talking about the clinical test, we have mnemonics for that: B, C, D, H, R. B for Brand's test. Anterior axillary fold is at lower level than the normal side. Callaway's test. Increase anteroposterior diameter of axilla at the head as the humeral head is displaced. Anteroposterior diameter will be increased. Dugas test. Unable to touch opposite shoulder. With affected limb, the patient is unable to touch the opposite shoulder. Hamilton ruler test. As there is flattening of the shoulder, when we place ruler on lateral side of the arm, this acromion process and the lateral condyle of the humerus, that ruler can touch acromion process and the lateral epicondyle simultaneously. Regiment Bad's test. Area of anesthesia around deltoid if axillary nerve is injured. Now, investigation. Most of the cases are diagnosed with history and examination alone, but we can perform X-ray. In AP view, overlapping shadows of humeral head and glenoid fossa is seen. Hill-Sachs lesion is seen based in the AP view. In axillary view, humeral head out of line with socket is seen. In MRI, bone lesions and labral tears are seen. In arthroscopy, it defines the labral tear. For the treatment, it is an orthopedic emergency, and before treatment, we need to rule out axillary nerve injury by regiment Bad's sign. There will be anesthesia in the deltoid region if axillary nerve is injured. We can rule out fracture by X-ray and rotator cuff tear. For conservative method of reduction, we do close reduction under general anesthesia. There is three methods: Kocher's method, Hippocrates method, and Stimson's method. Kocher's method is the most common. In this, first traction is applied, longitudinal traction is applied, then external rotation, then adduction, then internal rotation to lever back the humeral head into in its position. In Hippocrates method, surgeon pull the arm on semi-abducted position and put the foot in axilla and and taking as foot as fulcrum, head of humerus is levered back in position. In Stimson's method, keeping the patient in prone position, and then when we wait for spontaneous reduction under the gravity. On surgical management, arthroscopic anterior stabilization surgery, talking about posterior dislocation. In posterior dislocation of shoulder, there is always history of electric shock and seizures, and the attitude of arm is adduction and internal rotation. And in inferior dislocation of shoulder joint, also known as luxatio erecta, in this attitude of arm is overhead abduction. So it is called erecta as arm is kept in erect position.